Hello everybody, welcome to the Musculoskeletal 1 Orthopedics course. This is Eric Chaconis, and I'm going to be going over the first lecture here, the first presentation, which is on the topic of the physical exam. You're going to want to watch this video over the weekend and come to the first class prepared with this information. We're going to discuss this topic with good detail on the day of our first lecture, in-class lecture. And so make sure you have a solid understanding of everything that I'm covering here right now. You're also going to do a quiz next week on some of this topic, and I'll talk about that a little more here in a second, highlight some of the information that'll be on that quiz. So the first, I think, thing to establish is kind of why are we doing the exam? Why does a physical therapist do an exam? And it's really all about making appropriate treatment decisions, right? Using your critical thinking skills and clinical reasoning to make treatment decisions. You wouldn't be able to make appropriate treatment decisions without good, solid baseline exam data, right? So you have to do a thorough, comprehensive physical exam in order to make the appropriate treatment decision. If you just did the same thing on every patient, right, every person that comes in with low back pain, you do the same hot pack, ultrasound, massage, same 4 or 5 exercises, that cookie cutter approach, your exam might not need to be as detailed, but that's terrible. I mean, that is not what we do as physical therapists, and shame on the people that do practice in that way. That's not how you're going to be. So that's why we do a thorough physical exam, is to get as much information as possible. And it's a dynamic process. We're constantly reevaluating the patient, constantly monitoring their response to our interventions and modifying treatment appropriately. When you compare the exam that you're going to do, that you're going to learn, to that of the physician, it is very different. Most physicians, primary care physicians, the goal in the exam really is to make sure, first and foremost, that the patient doesn't have any red flags that would warrant maybe a referral or more diagnostic imaging or lab work. But after that, it's really primarily just, do I want to prescribe this person an anti-inflammatory or a pain medication, or do I want to refer them to another provider? You don't need to do a very comprehensive, thorough exam if all you're trying to do is decide whether to give somebody an anti-inflammatory or send them to a physical therapist, right? Whereas we as physical therapists need to do a very detailed, thorough, comprehensive physical exam, because we got to figure out what's causing this person's problem. What's their movement dysfunction? What specific tissue is at fault? What part of the musculoskeletal system is contributing to that tissue pathology? So we got to figure all that out, and it's a little bit more involved. The physician's exam usually will rely significantly more on imaging and laboratory work, which may or may not be indicated for the case. We as physical therapists will use imaging. We will use laboratory work very sparsely as a component of our exam, but not nearly as much as the physician. This is your exam, your 18-step exam, so you're going to want to memorize this. This is what the quiz will be on. So we're going to say, one day next week, we're going to say, write out the 18-step exam according to Patla in sequential order, and you'll do that. So make sure you memorize this exam in sequence. It is in a certain order for a reason. Each step kind of builds on the one before it, and there are certain intricacies within this exam of why a certain step needs to be after another. And for example, we want to check number 7, passive movement, joint mobility, and all of that before we start doing our contractile testing, our muscle testing. Because if a joint doesn't have good mobility, it could potentially impact the way that the muscles function, and that could potentially give us different findings for our exam. Imaging is at the end, for instance, because we don't want to be biased by the image. An image is a picture in time. You don't really want to look at that information till the end of the exam so that you correlate the imaging findings to the exam findings. There's just a couple examples. So when you memorize it in order. Evaluation is the synthesis of that exam data. So evaluation, you're taking all of the data from your exam that you collected from all of those steps, and you're basically analyzing it to provide the patient with a diagnosis and make treatment decisions. Sometimes your diagnosis is the same as the medical diagnosis, sometimes it's different. It just depends. A couple examples. One example would be an MD sends me a patient and says the diagnosed patient with shoulder pain. We'll have to look at that a little more detailed and figure out exactly what tissue within the shoulder is at fault, what's contributing to it. So maybe my diagnosis is supraspinatus tendinopathy. Right? It's a little more specific than shoulder pain because I had to figure out this specific tissue at fault in order to make appropriate physical therapy treatment decisions. That's just an example of how they could be different. It could be the same though. You know, sometimes you get patients who'll be sent to you and it'll say a diagnosis of a tibial meniscus tear. You examine the patient, you agree, yes, tibial meniscus tear. That's their diagnosis. In that case, they're the same. This is a patient-client management model. You see this in the Guide to PT Practice from your Practicum 1 course. And the patient's in the center, but it all starts with an exam, which is collection of data. Evaluation, synthesis of that data from the physical exam, labeling the patient with a diagnosis, coming up with a prognosis, which is your hypothesis as to how well they're going to do, how quickly they're going to get better, and what level they're going to get back to. And then intervention, which is your treatments. So you treat the patient, measure your outcomes, reassess, and then do it all over again. It's a process that occurs more or less within each time you see the patient. This is the ICF model. You're familiar with this, International Classification of Functioning. And I'm not going to harp on this, but I just want to highlight where the exam falls into this process. You gather impairments from your exam findings, and you try to correlate those impairments to how they relate to activity limitations, right? What's the patient not able to do, and how does that impact their participation? So you will measure activity limitation with one component of the physical exam, but for the most part, the physical exam is picking up impairments, and then you're going to correlate those to function. We're not going to get into the practice patterns, but just showing you where that kind of fits in from the Guide to PT Practice within this process here. These definitions are all pretty straightforward. I'm going to let you look these up, and we'll discuss in class a little more. All right, so we're going to talk about how you get a tissue-specific impairment. This is really important. It all comes from the exam step, all right? So in this case, we have an exam step or an exam test, which is a manual muscle test for this example. A manual muscle test is a strength test. We're going to do it for the biceps. So we manual muscle test the biceps. That's the exam test. From that test, we gather a finding. In this case, the exam finding is a 4 out of 5 strength of the biceps. So that's a grading scale of how strong the biceps is, and in this case, we scored it at a 4 out of 5. It's not at its full strength that we would expect it to be. So that from that finding, we're going to gather this tissue-specific impairment. The tissue is the biceps muscle. The impairment is that it's weak. In that case, the impairment, the tissue-specific impairment was more or less the same thing as the finding, right? 4 out of 5 or a weak biceps was the finding. Tissue-specific impairment was a weak bicep. So that was an example of how they were the same. There will be some examples of when they'll be different, and I'll highlight that in our class discussion. But what you want to think about is what are all the tissues in the body? And what can go wrong with those tissues? And that's basically what gives you your tissue-specific impairment. Everything we do with our physical exam is all about finding the tissue-specific impairments, and then we're going to treat those tissue-specific impairments. When you're naming a tissue-specific impairment, you've got to include, like I said before, both the tissue and the impairment. If you were using a term like syndrome, if you said shoulder impingement syndrome, That's not a tissue-specific impairment, right? Shoulder's not a tissue. It's a region or it's a joint. And impingement's not really an impairment. It's too vague. A better example would be supraspinatus tendonitis. The supraspinatus tendon is a tissue. And the fact that it's inflamed, or an itis, is an impairment. So that's more specific. That's the way you'd want to name it, right? Here's an example of how you can kind of correlate the two. The tissue is the muscle. Now, for it to be tissue specific, you'd have to name the muscle. So you say biceps muscle. The impairments are, these are your options, basically. What could go wrong with that biceps muscle? Well, it could be weak, biceps muscle weakness. It could be tight, biceps muscle tightness. It could be torn, right? Complete tear of the biceps muscle. Those would all be tissue specific. Those are all examples of tissue specific impairments. We're going to go through the 18 steps pretty much line by line now. It's critically important that you understand what you gather from each of these steps. It's a fundamental component of this course. Number one is pain. We will measure pain. Patient comes to see us and we will have them fill out forms that measure their pain, or we'll ask them on a scale of 0 to 10, 0 being none, 10 being the worst, how much pain do you have? And they'll say, I'm at a 5. Okay, well, you just measured their pain at a 5 out of 10. It's a good measurement for pain. There's other examples here. I'll defer all that to Dr. Paris. He's going to give you you have a 2-hour lecture from him on pain on the portal here, so I encourage you to view that. Initial observation is the next thing. And this is basically the patient walks into the clinic and you're just kind of looking at them. You're just kind of casually observing the way that they present. How do they get up from a chair? How do they go to shake my hand? You know, it's a very vague, very general thing. You're not gathering a whole lot of info here. You are essentially just getting a general idea. You can't get a diagnosis from it. So she's just checking her out. It's not a big deal. You can't get a tissue-specific impairment, and you're not going to be able to get a diagnosis from that, right? Just from looking at somebody and seeing that they don't shake your hand with their right hand, and instead they offer you their left, that doesn't tell you what's wrong with them. It just tells you, generally speaking, that they don't want to use that right arm. The history is next, and this is you sitting down with the patient, interviewing them, listening to them, and this is probably the most important thing that you will do. You're going to gather so much information from the history, you'll be able to develop a hypothesis by the end of that history. And from that hypothesis, you'll be able to test it with your physical exam. So good clinicians can almost get an idea more or less what's going on with somebody just by doing a history. And then the physical exam is like icing on the cake. It's confirming or refuting that hypothesis. Here's some examples of questions or topics that you will try to ask questions about with the history. We're not going to get into this much right now. We do a thorough training for you on history taking in the mock clinic course in 3rd term and in the E1 course in 5th term. By the end of the E1 course in 5th term, you will be able to do a very, very thorough history off the top of your head with a blank sheet of paper. And we train you not only in what questions to ask, but how to ask them, how to listen, nonverbal skills, all sorts of stuff. It's pretty good. So don't worry about it right now. We'll get into it more later. Structural inspection is basically what you did in skills and procedures with a postural exam. Looking at the patient from the front, from the back, from the side, seeing if there's a curve in their spine, if one iliac crest is higher than the other. You know, it's an observation of their posture, basically, their structural posture. Measuring crest height, palpating the PSIS. These are just examples. Trochanteric position, fibular head, looking at the knees, right? Same thing, you're not going to gather a tissue-specific impairment from that. You're not going to get a diagnosis from that, but you're getting an idea of where they're at with their structure. It's important to recognize that you see stuff and it may or may not be problematic or may not be normal. A lot of people have postural changes or structural changes that are normal for their body type or normal for them. You also want to delineate out, is this a structural thing, a postural thing, or is this more of a movement problem or a functional problem? And you'll do that with the rest of your exam. But I think my main point here is don't get too caught up in structure or posture. It can be good information, but a lot of times people make it out to be more than it really is. Step number 5, palpation for condition. This is gently placing your hands on the patient's limb to try to obtain information relating to temperature changes. Is there any edema or swelling in the area? Right? Edema is swelling outside of the joint, extra-articular swelling. Effusion is swelling inside the joint, or intra-articular swelling. So you're going to delineate that out. Edema, you'll figure out if they have that with this step, step 5, palpation for condition. You might suspect that there's swelling in the joint, like for instance, the knee is swollen, and you palpate the knee for condition, and you say, I think there's some swelling inside this joint. But it's not the best way to pick it up. You're going to have to passively move that joint to try to feel that effusion. So effusion swelling inside the joint can be suspected in this step, but not best found in this step. Example for palpation for condition, you're just loosely palpating the area, feeling for warmth or swelling, changes in muscle tissue, right? You can measure it. You can get a quantification of the limb girth, and that's a good way to objectively measure the amount of edema that might be in the area. We talked about this already, but just to reiterate, edema is extra-articular, it would be defined as extra-articular swelling, and effusion is intra-articular swelling. Active range, step 6, just having them actively move, right? There's a lot of words here. I would focus on 3 things. Quantity of movement, right? You go to actively move, and we measure how much do they move, how far do they move, what's their range of motion. That's quantity. Quality is how well do they move. Do they compensate? Do they shake or judder when they move? So that's quality. And then the third thing is pain. Do they have pain when they move? Is it at end range? Is it throughout the range? Those are the 3 main things that you're really looking at when you look at active range. Quantity, how much, quality, how well, pain, presence, or not. So active range quantity, we take our goniometer and we measure how much elbow flexion is present. Active range quality, we observe that movement and just look to see how well they move from a qualitative standpoint. All right, step 7, passive range of motion. The course heavily emphasizes passive range of motion. That's where you learn all your joint mobility testing and treatment. We break passive range down into 2 components. Classical range is what you already think of when you think of passive range. That's moving the limb through a range of motion, right? That will be synonymous with osteokinematic movement or physiological movement. All 3 of those terms mean the same thing. Moving a limb passively through a range of motion. Accessory movement is really intricate movement of the 2 joint surfaces. Finite movement of one joint surface gliding or rolling on the adjacent joint surface. So that can also be termed orthokinematic movement. Accessory and orthokinematic are synonyms. Ortho meaning joint, kinematic meaning motion, makes perfect sense. The 5 pieces of data that we're going to look at with passive range, anytime we do step 7, we're going to gather the classical motion, how much, right? Quantity. goniometric degrees of movement. How well? Quality. That's your end feel, right? Soft, firm, hard. What's the end feel when I move that joint or that limb through its range of motion? And then for accessory, you're going to look at quantity. Is it hypomobile? Does it move too little? So you grab one side of the joint and you glide it on the next. And you say, you know, that feels like it doesn't move very much. That's hypomobile. Or is it moving too much? Hypermobile. Or of course, normal. And then quality, once again, the end feel. What's the end feel that I get when I do that joint accessory movement? And then is there any change in symptoms? Here's an example of an accessory movement. This is a distraction of the ulna, where we take the ulna and pull it away from the humerus. That would be an accessory movement, right? Or an orthokinematic movement. We're moving one joint surface on the other. That's an orthokinematic technique. Here's another one. This is a glide. We're going to glide the radial head on the humerus. Glide it forward, glide it back. Just moving that radial head back and forth on the humerus. That's another accessory technique. So those are examples for you. You're going to need to memorize these end feels. Page 35 and 36 in the E1 manual. So Dr. Patla has developed an expansive list of end feels, much more than what you're familiar with from skills and procedures. Basically taking that list and just expanding on it. The 5 normals are listed here for you. They're pretty straightforward, right? You get to the end range of motion and you feel soft tissue approximating within the limb. That will be your soft tissue approximation. No different from what you learned in skills and procedures. Different ones or new ones, like normal capsule. You take the shoulder out in a full external rotation, stretch it all the way out, and you feel a firm capsular end feel or normal capsular end feel. There you go, normal capsular end feel. So memorize those. We'll discuss them more in class. And then your abnormals, there are 9 of them. Capsular tightness is when the whole capsule gets bound down or tight. So think of the capsule as like a sort of loose ligamentous type of bag around the joint. And that bag or that capsule can get like shrink wrapped down around the whole entire joint. It gets really tight. You lose motion in all directions. The end feel that you would expect in that case is a capsular tightness end feel. It's a very firm end feel. Joint adhesion is scar tissue. You get a little scar tissue in the joint. That'll block motion. You'll feel that with an end feel. Bony block you know about. These would be abnormal cartilage and meniscus, like tears in the cartilage and meniscus, where you feel clicking, popping within the joint when you move it around, maybe because of a cartilage tear. Pannus is like fibrotic tissue you see with like something like rheumatoid arthritis or an inflammatory condition where there's fibrotic tissue within the joint. It's kind of crunchy and you feel that when you move the joint around. Laxity is pretty straightforward, right? A loose joint, you might feel that. Now this one, swelling, number 9 here, that is your end feel that will pick up joint effusion, right? We said that joint effusion is swelling inside the joint. That is best detected under this step 7, accessory mobility testing. We glide that joint back and forth and we feel fluid within the joint. We feel a swelling end feel. There you go. You could diagnose that person with a joint effusion if you felt that. Here's some examples of impairments that we'll see with the joint capsule. So you have joint capsule as your tissue. Make it specific. Say glenohumeral joint capsule. Tight glenohumeral joint capsule. Well, there you go. That's a tissue-specific impairment. The impairment is that it's tight. The tissue is that glenohumeral joint capsule. Same thing for the rest of these. Glenohumeral joint effusion. Right? Well, that's a tissue-specific impairment. You're saying glenohumeral joint is the tissue, and then effusion is the impairment. If you have that tight joint capsule, what you will see is limited motion in all directions. So it's a pattern of motion loss where one motion will be limited more than another motion, but they're all tight. You'll see it with active movement, you'll see it with passive movement, and then your quality, right? What infield would you expect to get for classical? What infield? Tight capsule infield, right? When you look back to that list of abnormals, this one makes the most sense, doesn't it? Makes the most sense if I have a tight capsule pattern of motion loss, that capsule tightness would be my end field. And then when you test them for accessory, you glide the joint, you're going to feel like it's going to be hypomobile, right? It's going to be hypomobile. It's going to be a loss of motion because it's tight. And then your end field should be a tight capsule end field for accessory as well. If you have a capsule pattern restriction, you have a tight joint capsule, you got motion loss that is due to the inert structures, the capsule structures, not the resisted, not the contractile tissue, right? You have these listed out for you. Page 33 in your McGee text gives you all of the capsule patterns for all the joints in the body. Another important concept as it pertains to the joint laxity, joint laxity. You would expect if you had a laxity that person's going to have excessive movement, right? Well, not always. Sometimes a laxity can present as a loss of motion, and you want to be able to pick this up. There's three theories. One is biomechanical. There's an altered congruency between the two joint surfaces, right? So if I have a laxity in my shoulder, my head of my humerus sits a little inferior to my glenoid, I go to raise my arm up and I get a loss or a jam, a loss of motion. It's a biomechanical reason, right? There's an incongruency in the joint surface. Neurophysiological and pain kind of go hand in hand. These are basically, if you have laxity, maybe you have some pain, maybe you muscle guard. Maybe the muscles around the joint shut down, don't want to let you move. So, the person could guard, could stop you from moving them. MSTT stands for muscle selective tissue tension. This is step number 8, and the reason you do this one is to try to pick up a muscle or tendon problem. Contractile tissue problem, right? Perfect. So you isometrically resist the person doing a movement. In that case, we resisted elbow flexion and elbow extension isometrically, trying to see if they have any pain or any weakness. So from your findings from that MSTT, you'll be able to try to pick up one of these impairments. We'll talk about this later. We're going to do a whole lecture on MSTT, or a whole lab on MSTT. So you'll figure out how to use an MSTT to try to detect some of these problems. Tendonitis, tendinosis. Tendonitis is an inflamed tendon. Tendinosis is a more degenerated tendon. Partial tears, complete tears. Step number 9 is muscle length test. And you're going to try to stretch the muscle to see if it's tight or not. So in this case, we'll muscle length test the biceps. Take that biceps in the motion opposite of what it performs. That will stretch it, and we'll be able to detect if it's tight or not. So your impairment, right, if you found a tightness with that, you'd say biceps muscle tightness, or tight biceps muscle. That's a tissue-specific impairment. You said the tissue, biceps muscle. You said the impairment was that it was tight. Manual muscle test is a strength test. You're using it to try to measure how much weakness or how much strength the person has in their muscle. So here's an example of the biceps. We ask them to hold, we try to pull them out of the position, and we gauge the amount of strength within the biceps. Here's for the triceps. Hold, don't let me move you, trying to push them out of that position, measuring the strength of the triceps, right? If you found any loss of strength, the TSI, the tissue-specific impairment, would be biceps muscle weakness. That would be your tissue-specific impairment. All right, next one is special tests. These are certain maneuvers, provocative maneuvers that you're going to do to try to diagnose somebody with a certain condition. You can sometimes already have a hypothesis of what's going on, and you simply use a special test to confirm it or reject it. There's also times where the special test by itself, standalone, will be your best test. That'll be your diagnostic test of how you detect the pathology in the first place. What you should recognize is that some tests are better than others. They're not all equal. Some have good reliability and validity, some don't. Here's an example of an elbow. Valgus stress. We put a valgus stress through the elbow to try to test the medial collateral ligament. So we test the medial collateral ligament of the elbow by putting a valgus stress through it. That's a special test. That's a valgus stress test of the elbow. Use it to pick up a sprain of that ligament. Movement analysis, you're going to do a movement analysis in order to try to measure the person's functional activity. So we might ask them to squat. We might ask them to step down off of a step. We might ask them to run. We might ask them to reach a box overhead and put it on a shelf. Whatever it is, it's just got to be functional. You're measuring observing their functional movement. So here's just an example. We observe the patient lifting up objects, putting them on a shelf, right? Looking for compensations, watching the way they perform the movement, and analyzing it. Palpation for tenderness is going to be basically palpating a tissue, pressing on a tissue to try to see if it hurts. So we'll do it towards the end because we already kind of have an idea. We already have an idea, say that it's the medial collateral ligament of the elbow. And we did that valgus stress test and that hurt. And now maybe we want to palpate that tissue to see also does that hurt. And that'll strengthen our diagnosis. There's some limitations to palpation for tenderness. It's subjective. You're requiring the patient to tell you if it hurts or not. And it's hard to test the reliability of it, but palpation for tenderness can be a helpful test. Just some examples, and this is no different from what you did in anatomy. Press on the tissue, see if it hurts. Single finger, right? Comprehensive, thorough. Hit all the tissues in the area. Neurovascular. This step is called neurovascular. That should say neurovascular because you're testing the nerves and you're testing the vascular system as well under this step. So we test the nerves with reflexes, myotome testing, dermatome testing, right? Checking sensation and the distribution of that nerve. Neural tension is stretching a nerve. We can do specific maneuvers to stretch nerves, and that's neural tension. And then obviously vascular testing by taking somebody's pulse would be a way to measure their vascular function. So here's sensation testing. Muscle testing, myosome testing, pulses. Imaging is at the end. Like I said earlier, imaging is at the end because you want to correlate the imaging findings to your clinical findings. An image is a picture in time. Just because somebody has a finding on an image doesn't mean that that's their problem. If you MRI 100 people with no back pain, 60 of them will have herniated discs. If you take x-rays of 100 people with no knee pain and they're older, half of them are going to have signs of osteoarthritis or osteoarthrosis. So imaging can be helpful, can be very helpful to help us think, but it also can be very misleading. So you got to be careful. The other thing is an interdisciplinary approach. The radiologist, the orthopedist, the primary care physician will look at an image very differently than you as a physical therapist will. We as physical therapists look at images differently. You know, we're looking at at muscle atrophy. We're looking at fatty deposits within muscle. We're looking at edema within the bone tissue. Things that oftentimes a radiologist may or may not report on their clinical impression or their exam, their imaging impression. So it's good for both of you to look at it and to collaborate. Obviously, you can look at an X-ray. It's pretty straightforward. Diagnostic ultrasound is another thing that we as physical therapists will use as an imaging modality.
Now with your left hand, point on the screen.
So you can see she's very nicely pointing on the screen for the image, showing you basically where she's looking at the soft tissues of the ultrasound. We have 3 of these machines on campus. We use these. I pretty much ultrasound almost every eval I do. I ultrasound the soft tissues if I'm worried about soft tissue damage, to just kind of clear it and make sure there aren't any muscle tears, tendon tears, ligament tears, stuff like that. Diagnostic ultrasound can be very, very helpful to your exam. So to wrap it up, the end of the 18 steps, evaluation, right, your synthesis of everything, giving them a diagnosis, and then deciding on interventions. It's part of the whole process. So that's what you do. You sit down, you analyze everything, you look at all those exam findings, and you come up with a diagnosis and a treatment plan, and you do it very confidently. So that's it. By the end of this course, by the end of this semester, you will be able to do a thorough comprehensive exam on a patient. You will be able to diagnose somebody with a musculoskeletal injury or pathology, and that's basically the goal of the course. So we look forward to working with you. It's going to be a fun, exciting semester, and be ready to discuss this topic in class in the next class session. Thank you.